So KEYNOTE-355 is a randomized placebo-controlled trial that evaluated the efficacy and safety of adding Pembrolizumab to a menu of chemotherapy as first-line treatment for metastatic triple-negative breast cancer. And patients had to be at least 6 months from their last treatment with curative intent. They could receive paclitaxel, nab-paclitaxel, or gemcitabine and carboplatin as the chemotherapy partner, and then they were randomized to receive Pembrolizumab or placebo. In patients who had stable or responding disease, you could stop the chemo and continue Pembro alone. Similarly, if you had a reason to stop the Pembro, you could continue with chemo alone. Obviously, only a small number of patients discontinued the Pembro and continued chemo alone. So we were really interested in what happened to the patients who stopped chemo before the progression of disease and just continued Pembro alone. So can Pembro work as maintenance therapy? And what we saw was very good outcome. You know, you're already selecting the group of patients who have stable or responding disease. You know they're going to do better than the intent to treat population. But the patients who were on chemo and stopped early seemed to do, in some ways, even better than the population of responding patients. They did very well. It's hard to make any inferences except for to say that maintenance Pembrolizumab appears to be a reasonable treatment option that's safe and effective for patients who have stable or responding disease for chemotherapy. Now, that doesn't mean you should give 2 cycles of chemo and stop your chemo. You want to treat with chemo to best response, but then you can safely stop chemo and continue Pembro, which I think is really important for patients' quality of life and potentially having a chemo, so-called holiday. And so that was very interesting data. We also, and there's more, I think, in-depth analyses that potentially can be done, but it is still a subset, unplanned post-hoc analysis. We also did another post-hoc analysis, and we looked at what happened to patients who had immune-related adverse events. They call them immune-mediated adverse events for the purpose of this analysis. And what we saw was that patients who had immune-mediated adverse events, if anything, had a better PFS and OS than patients who didn't have them. And we didn't actually look at having immune events or not. We looked at having immune events and then the whole population. So we weren't selecting out that group. And it is post hoc and obviously somewhat biased. But it was intriguing to see that patients did a little better. And there's other data in the literature with other cancers that are even more immune responsive that the presence of immune-related adverse events may correlate with better outcome. Now, we looked at both the chemo discontinuation outcome and the immune-mediated adverse events by PD-L1 status because KEYNOTE-355 showed a benefit with adding Pembrolizumab to chemotherapy in the patient subgroup who had PD-L1 positive disease defined as a combined positive score of 10 or greater. But it looked like this differential was true regardless of PD-L1 status. Both the good outcome in patients who stopped chemo early and continued Pembro, these are the stable or responding patients, and you wonder if Pembro has some effect as maintenance even in PD-L1 low disease. It's just hypothesis. And then the same was true of the immune-mediated adverse events, that maybe that does help to improve outcome even in patients whose PD-L1 is not 10 or more. So this is really interesting data. It's obviously not any kind of definitive statement about patients doing better or have immune-mediated adverse events, but it definitely, I think, merits further evaluation in a real-world setting and in future trials.